So I'm pleased to welcome from day one both Cherl Daly and Annie Akers, who will be talking about exploring the use of harm reduction in therapy.
Thank you. Good afternoon. Like he said, I'm Cheryl, and this is my colleague Annie, and we're going to talk to you a little bit about exploring the use of harm reduction in therapy. Our population that we work with is adolescents, but the work that we discuss can be translated to anyone that you work with. A tiny bit of background about me, and also Annie. We're both dually licensed clinicians. I have been a clinician and a program manager for the Day One Street program for 14 years now, working with homeless youth. And I have learned early on that this approach is the one that works for me, not only in practicing therapy, but in all my previous roles. Back in 1993, I did my first internship when I was working on my bachelor's degree as a juvenile probation officer. And I didn't have the words for the clinical process to know how to say what I thought what worked and didn't work, but the person that I mentored under presented as significantly punitive and did not take time to build relationships. The youth often left angry and defensive. I myself have worked in the homeless community in some capacity since 1994. I quickly came to understand that using substances is a way that people cope with feelings. I lived and worked in San Francisco when medications were finally starting to work with HIV and AIDS, but couldn't understand that when people entered treatment, which was abstinence-based, they had to hand over their Marinol cards. I lived in New York City and worked at a harm reduction agency, Housing Works, that provided day treatment to people living with HIV and dealing with substance use and mental health issues. I worked in Boston as a Ryan White case manager and did street outreach and ran groups for transgender individuals who are actively engaging in the exchange of sex for money. And through all these experiences, I learned that harm reduction is the only approach to treatment, or I should say the first approach to treatment for me that is effective. I went to graduate school here at UNE in 2003 to become a therapist because it's what I value most is relationship, and frankly, I was a shitty caseworker. Now Annie's going to talk a little bit about herself.
Hi, everybody. I'm Annie Akers. I grew up here in Portland and moved back after grad school. I also have worked with and within the homeless population for a long time, for most of my career, starting in Vermont at the family shelter in Burlington. And as the daughter of a public health nurse practitioner, I would think I was drawn to this work because I kind of grew up with an awareness of the plight of the human experience and how important it is to meet people where they're at.
Okay, so there we are at Happy Wheels. The street program is made up of two dually licensed clinicians, Annie and I, and an intensive case manager. We are based out of the Preble Street Teen Center, which serves youth under 21. As clinicians, we are expected to uphold clinical standards in a non-traditional environment. In theory, we are also expected to have an assessment and a treatment plan within 30 days. We are expected to bill, but thankfully also receive grants and funding from places such as the United Way that believe in our work and understand the importance of low barrier access. We work with adolescents, homeless youth, individuals who have experienced sex and labor exploitation, and young mothers and soon-to-be mothers. We are able to see youth after they age out of the teen center at age 21, and this is often when they are ready to do some therapeutic work. Sometimes it takes years to get to a point where a client will even enter our office because they've had such negative mental health experiences and substance use treatment experiences in the past.
So can you hear me if I'm back here? Yeah? Okay. Just raise your hand if you can't hear me. I'll stand closer. So this is an overview of some of the stuff that we're going to go over today. But we really, really, really felt like it was important to acknowledge that we are by no means experts in this field. We simply have experiences of our own that we hopefully are sharing with you in a helpful way, in a way that you guys will be able to kind of translate into your own practices and whatever those may be. And as I'm saying that, we also are hoping that you guys will let us know a little bit about what you all do and who's in the room. And so Cheryl is going to ask you now a couple questions for us to figure that out.
Yeah, I'm just curious who's here. I'm wondering how many people are clinicians, if you could just raise your hands. Oh, awesome, okay. And medical providers in some capacity? Okay. Lawyers or lawyers? Law enforcement? Okay. Case managers? Nice. And substance use providers? Nice. Anybody else? Huh?
Educators?
Educators, yes, I meant to say that. School-based individuals, yes, thank you.
Well, thank
Okay.
All right, so before we get started, we're going to lead you through a quick exercise. We want all of you to think about what is your go-to coping tool.
You don't have to say it out loud.
We're not going to ask you to share with your next door neighbor or anything like that. But literally, like, what are you looking forward to when you leave here today for yourself? What are you looking forward to going home to do? What is your kind of guilty pleasure, whether it's guilty or not?
So just, sorry.
Some ideas. This was in the beginning of making this presentation when we
We thought we'd
were
be fancy.
exploring all the effects on. So just for some ideas on there, but really think about what is it, even if it's not something that you really would ever want to acknowledge to anybody else, but what soothes you? What helps you get through stressful times? What do you know that you can do for yourself? Now we want you to picture this.
So you finally made the decision to make an appointment with that therapist your friend recommended to you to discuss the increasing stress of your job. You sit down the first session, you're super anxious, and you start kind of running your story to the therapist. You tell them about a day in your life, what's stressful, and you expect to get validation around how stressful things are and how you manage them. You identify some coping tools that you find helpful and or soothing. The therapist listens intently and takes ample notes. In the last 15 minutes of your session, they reflect for you what they've heard you say and begin to formulate treatment goals for you. The therapist identifies one of your go-to coping skills as being maladaptive due to its potential for causing harm and assumes that it's something that you want to stop doing. You had just come to this therapist to discuss your work-related stress. Now, how are you feeling? Anyone?
Yeah, so really, how do you think that you're feeling if you are in this situation? Just shout it out. Frustrated, terrible.
Judged, yeah.
Defensive.
Right.
What'd you say? Something else over here? Invalidated.
Yeah.
Not coming back.
That's right, absolutely not coming back, all set.
Yeah.
Good.
Yeah.
Right.
Yes, exactly. And so we wanted to kind of bring you guys to that place where clients often feel when they are sitting in a very vulnerable position in that client, patient, consumer chair, and tasked with the kind of task of telling their story and being vulnerable and then being judged for it, right? So we want you to remember this feeling as we're going through the rest of this presentation and hopefully in your own practices outside of here as well.
Okay. So when we looked at our slides on Monday when we turned them in, there's things we would have changed, but we're gonna pull from what we have here, okay? But why we practice harm reduction? Well, we have a core belief that there's a reason that you come to depend on the activity or the behavior or to deal with your distress. In the case of the people that we work with, but let's be real, in the case of most individuals in this world, we have experienced some sort of trauma that has an impact on our overall well-being. Telling your client that they must do something, no matter the reason for your concerns, really does deny the fundamental complexities of their overall human experience.
And the beauty of the harm reduction approach, especially as we're applying it to our traditional therapy practices, is that you can use it with any behavior, any event, any kind of anything that we do often, right? It doesn't just have to be about substance use. It doesn't just have to be about other risky behaviors that we think of when we think of risk, right? It can be an 87-year-old woman that would like to be healthier and wants to take her medication daily. It can be a college professor who wants to address his cigarette smoking, but maybe isn't really ready to completely quit. There are so many gray areas in this experience of how we live our lives. And so I think that that's kind of the most important piece here, is meeting the client where they're at and remembering that they're the experts of their own experience.
And I guess I would also say that we have on here, the behavior is not the diagnosis. I mean, so often, and you hear how important the use of language is, but referring to someone as an addict, referring to someone as a crackhead, referring to someone as a schizophrenic. And let me say that some people do identify it as an addict, and that's not a negative thing. That is how they choose to identify. But when we're talking about clients or talking about issues people are struggling with, like, they are not a crackhead. Crack is something that they use to deal with their stress. So it's just really important to keep that in mind.
So this is just an infographic. It's a fun word we learned while we were getting ready for this
favorite
presentation. Can you guys hear me over there even? No, okay. So this is just a fun infographic that we found while we were getting ready for the presentation that we thought was a perfect representation of what harm reduction is. And if you can't see it in the back, it says, what is harm reduction? Harm reduction is a philosophy that people will engage in at-risk behavior, drug use, unsafe sex, etc., going back to kind of what we think of in our mind when we think of risky behaviors, no matter what. Harm reduction helps people learn how to reduce the harm of those behaviors to themselves and to their community, and also provides them with services and referrals. So it's not just about the work we're doing in our offices, right? But it's about the connections that we're helping our clients, consumers, patients make outside of our offices as well. All right, so we just wanted to give you a little bit of an understanding of our setting, where we work and where we do therapy with our clients. So our office we are part of the Preble Street Teen Center collaborative. Our office is in the building where the teen center is. So we have, I'm not going to get into that, but so I chose this picture because it is the Google Maps Street View image that if you Google 343 Cumberland, where the teen center is, as of yesterday, Cheryl is in the picture outside, outreaching a client. And I just thought that that was such a perfect example of the way that we engage with our clients, and also assuming that this client is probably aged out, in that meaning that it's harder for them to access services elsewhere, because within the collaborative, so many of the services are there for them. And once they are not part of the Teen Services program anymore, it is much, much, much harder to get all of your needs met.
Okay, so really quick, so the street program, like I said, is traditional work in a non-traditional setting. We're lucky in a lot of ways as opposed to you guys who are in private practice. We're working with clients that are in significant crisis, either mental health, substance use, a lot of crisis, but we have each other and we have a collaborative wrapped around us, and so it makes our job a lot easier and more effective. We work in collaboration with Portland Adult Education, so the youth that access the Teen Center can also be meeting. We have 2 teachers on site, so they can be working on their HiSAT or applying for jobs or building a resume. We work with the City of Portland Public Health, who have a clinic several times a week, and so we have crossover with the health providers and a really good open relationship. So if someone meets with me, I think they need to be on birth control. Shout out to Peggy Akers. I can give her a phone call and she can come over and be like, hey, how are you? And we can just play off of each other and try to make things happen in that moment. Preble Street, at the Teen Center, they offer 24-hour services, either people during the day or at the teen shelter, and then or at the day shelter, and then at night or at the teen shelter. So in some ways, we get, through collaboration with the staff that work all the time with the youth, we get more information than we would ever have from an hour session once a week. And sometimes I say to people that I worry more about the high schoolers that are at home secretly using and not divulging this to their parents versus the homeless youth who at least are under the eyes of adults and trained adults, right? Annie and I, it's just she and I that are next to each other in an office, and oftentimes it'll be like, we just got this youth from New York City, we think we're trafficked, they're homeless, we don't know if, they're minor, and so we're trying to like evaluate this, and like maybe we'll bring them into our office, but our office is in the back, so she and I can communicate really well just by looking at each other, be like, hey, can I show you this fax for a second? And then be like, okay, if this person freaks out, come knock on the door in 2 minutes, and we're constantly safety planning in that way with each other, which is super helpful.
And we also have to acknowledge here that a lot of other practices don't have all of these aspects to it. And so really, I think that that's just why we wanted to share our experience with working within the STRAIT program, because we do know that it's a special environment that is not easily reproducible, but that some of these aspects really make doing therapy from a harm reduction approach possible and much easier, I would say, as well. So these are some of the kind of takeaway points to remember that we are constantly reminding each other and ourselves of. First being, it's not about your agenda. I think we all kind of get that in theory, that it's always about the client's agenda and what they want to work on. But that is a lot harder to do in practice when you have a client sitting in front of you that you are terrified is going to do something that is going to cause them harm, right? So that piece in itself is just very challenging, and we want to validate that, and we'll be discussing it further.
And I guess I just wanted to say, at the core of my belief system also is that we don't change people and people don't change us. And I tell my clients that every day, when they're struggling with a relationship and they want, their partner to stop using. And, I just say, like, I've never changed anybody, have you? Yeah, never, not gonna happen. And I guess that's just like a good thing to remember.
And I just loved this quote from Jeannie Little, who is the co-founder and ED of the Harm Reduction Therapy Center in San Francisco. At times, people need someone to tell them what to do, and at other times, they need to work with someone who has the capacity for infinite flexibility and whose role is to facilitate their own exploration. And I think that there is space for everything between those two ends of the spectrum in your practice.
So, it seems like from like 2010 to 2014, people got mildly interested in harm reduction psychotherapy. So there was a lot of information produced at that time. And then recently, last month in the Psychotherapy Networker, there's people doing the work, I should say that, but in terms of publications, there's been a book here or there, but there hasn't been a lot in recent years. But the Psychotherapy Networker last month had a lot of harm reduction information. So if you like that magazine, that's a good one to pick up from last month. But what I did find, and what we found in our research, as we were going down the harm reduction rabbit hole, is the things that were most helpful, clearly, and this is never a surprise, are like the grassroots handbooks written by people that are on the ground doing the work. These are the people that really know what's going on. We can take it and we can translate it clinically, but the people on the ground doing the work are the true harm reductionists, and so that was the information that we found to be most helpful. Oh yeah, sorry. So what I went on a tangent, but the person who is most in the forefront right now is Andrew Tatarsky, and these are his 6 core principles of integrative harm reduction psychotherapy. And we're going to go through them, but number 1 is forging the therapeutic alliance. It's all in the relationship. 2, offering corrective emotional experiences. 3, teaching self-regulation. 4, assessing risk. 5, affirming the client's ambivalence. And 6, setting positive change goals.
And again, I think it's important for us to note that we are not at all experts on Tatarsky. However, his approach seems to be most in line with what we also are doing in our practice. And so just to give us kind of a fundamental approach to kind of go from and give you structure to what it is that we do, we felt like his was most in line.
Okay, so forging the therapeutic alliance. This is my favorite slide in the whole presentation, even though it's not pretty or exciting looking. It's all in the relationship. That is so important, especially working in the community that we work in. People can sense if you are not genuine a mile away. You better present with your authentic self, otherwise people are not talking to you. So again, keeping in mind that we have some traditional expectations around our clinical work, you know, when we finally do engage a youth with us and they've agreed to treatment, it's sitting down and having to sign some paperwork to get their history, to do an assessment, a treatment plan, and all that other fun stuff. So I try to be extremely transparent. I try to use humor. And so even when we start meeting, I'm like, all right, I have to take some notes because my memory's terrible. And so you've probably, you know, and they'll be like, oh, I hate that, you know, or you've probably, maybe you've had therapists in the past that took notes, like Glenn was saying this morning, you know, that they like write one word. I said, you can look at your notes at any time with me. You can see exactly what they say. I'm not writing, you're crazy. It's literally because I have no memory. So you're telling me that you're in love with, you know, Betty. Great, I'm going to write that down, you know, whatever. And so no one ever asks to see them, but they know they can. Also with diagnosis, sometimes they'll say, well, so tell me about your, you know, your past therapist, what was it like and what worked and what didn't, and you know, they'd be like, oh my God, they just stared at me and they nodded their head, like it said, and it freaked me out and I couldn't tolerate it, and I'll be like, oh really, say more about that, or you know, just like joke around trying to say like, I get it, and like, I'm not gonna do that with you. And then also I might ask like, what's your diagnosis? And people are like, I got bipolar, ODD, like a million things, right? And then I say, well, what do you think? Like, what do you think's accurate? You know? And so just kind of really involving the client in the process. Sharing a little bit about myself, I do ask my clients, you know, and this is a balance here. Like we always say, we walk the line, you know, but you know, is there anything that you need to know about me? Okay, so if it's something like inappropriate, I'm like, you know, I'm not going to answer that. But if it's like, are you in recovery? Are you, you know, like things like that, like I'm happy to answer. I'll offer up a little bit. And like, if I'm fumbling or making mistakes or I had something funny happen in the morning, I just like present as myself. And I think that that works with the youth. And yeah, that was a tangent, but yes. Andy's going to talk to you about number 2.
So Tatarski's second principle of integrating harm reduction into your therapy practice is to offer corrective emotional experiences, which I have understood to be basically doing the work around the underlying causes for why we're seeking relief in ways that may be harmful. The relationship that Cheryl was just talking about is the basis for where all of this work comes from. There has to be a safe, trusting, comfortable environment that the client knows and can depend on, and knows that you're going to be reliable in order to even begin to do this work, really. So many times I have referred a client to either a higher level of care or to maybe an outside provider because they've aged out of the teen center and it doesn't necessarily make sense for them to have to come back to the teen center to meet with us. And they come back to me at some point and I say, you know, well, what did they say about this? What did they say about your crack, you know, smoking, which they've expressed as a concern? And they'll say, I didn't tell them about it. I'm supposed to be completely sober, so I just can't talk about it. Which essentially means that they're denying the full range of the human experience and our ability to make decisions for ourselves as adults and as humans in general. So we've found that just doesn't work, expecting people to be sober. That being said, there are many settings and approaches where that does make sense and where supporting someone in being sober is super important. But for us, in order to connect with our clients, that is not how we can operate, essentially. So, again, harm reduction approach allows you to do the work with the client, even though they may not be ready to maintain complete sobriety. CBT, DBT, narrative therapy approaches are all great matches for the harm reduction approach because they really target the underlying kind of beliefs and issues that tend to cause us distress as we go throughout our daily lives, and then eventually cause us to seek relief from that distress, which often makes us use or engage in that same coping tool like that we were talking about from the first beginning of the session.
And just another note on that is like, first of all, working with adolescents. So like if you're like, we're going to do some CBT or DBT, they're like, oh, hell no. Because they've been in, many of them have been in treatment and they hear that and that's going to be in a workbook and that's just like all too much. So we try to take pieces of things like that, CBT and DBT, and just kind of like weave them in and
Sneak them in.
Yeah, and only give homework to people that like it's not going to stress them out, because sometimes I think that people won't come back to session because they didn't do their homework, and so what we think is like we're moving along in this workbook, we're not at all, so that's also just something to consider, but taking little pieces here and there.
And then I think another piece is also being ready to pause that kind of progress at any time that you might feel like you're kind of on a roll with the client and they're really getting this great work done, and then they disengage. And what do? Generally, I would come back to myself and say, what did I do wrong, right? Like why did I cause them to not come back? Over and over, we learn that that's absolutely not what's happening. For whatever reason, maybe they felt vulnerable, maybe something was brought up for them, maybe something happened completely outside of your office that absolutely has nothing to do with the work that you're doing, that's preventing them from coming back. And eventually, they almost all do come back to us. And the work starts again, and you reassess, and you may start over. You may have to now work on completely different issues or traumas that potentially have even happened in the time that they have been disengaged from you. It's a hard thing to sit with, and often we feel very scared for where our client is. Again, like Cheryl said, we have kind of a network of staff that we work with, and often somebody will know something about where the client is, which we are very lucky to have. But being able to sit there through that and knowing that this is part of the client's process, that not only in substance use treatment is that part of the process to disengage, but also in mental health treatment, and that it's not always gonna be stable all the way through.
Okay, so number 3 from Tatarski is teaching self-regulation. I joked to Andy, I'm like, if I figure this out, I'll let you know, because I just don't. I was freaking out before doing this presentation. But this is a hard one because, again, if people sense, and this includes me, if people sense that you're coming at them with some mindfulness grounding techniques and stuff, a lot of people enjoy that. Other people are like, oh, hell no, they don't have the distress tolerance for that. So again, it's knowing your client and how you can be creative. So, feeling charts, emotional thermometers, again, for some people that really works. Other people just are freaked out by it. Ease the language, saying things like triggers, cravings, and things like that. For some people really helps. For other people, it's nope, I'm not doing it. So just really knowing your client. This is pretty controversial in terms of traditional therapy. Are people allowed to have their phones in session? That depends for us because we work with youth who regulate with their phone. And we're not in a school environment, So if someone's just playing video games and not playing and they're just putting in their time, that's a little more challenging. But if we have some really high risk youth, so if they need to be in contact with friends and they're worrying about where they're going to stay at night and stuff, then I might allow for it. Or I might say, can you put your phone down for 15 minutes? Can you pick it back up? Just trying to be super flexible. And also there's apps now that people use on their phones, the Calm app and things like that. With homeless youth, it's a little bit harder because you have to pay for them. But there are some safety planning apps. I just learned of one the other day that's like you can put like 6 people in your network if you're involved in risky behavior so they can ping you. There's like something to look at if your clients are very phone involved instead of looking at it as a barrier, as looking at it as a tool. And I just had a tiny little example of teaching self-regulation. I did have a client this week successfully go up to Job Corps, but before she left, she was drinking almost daily, and she was using her vape, her Juul, and the day she was leaving, I said, oh, come to my office, I have something for you, and I was going to review with her kind of like how she's going to deal with her anxiety and all the other things. She's like, did you buy me a new Juul? No. Okay, well, she was really interesting. I'm like, I got you a magazine on cars. But it was like, I'm running my agenda. That's not her agenda right now. That's like what's on her mind. And I want to talk about, like, are you going to breathe through it? And she's like, do you have this? Because that's what I want. And Annie's going to talk to you for a couple minutes about urge surfing.
Maybe 1 minute at the most. But urge surfing is also a part of what Tatarsky talks about in teaching self-regulation around essentially just going towards your cravings to use or engage in that risky behavior instead of trying to push it away or say, like, feel shame that you have the urge to use. No matter what stage of change you're in or no matter what phase you're in your movement towards your treatment goals, I think that you can absolutely assess for kind of where your urges and cravings are coming up and being triggered. And the idea of urge surfing is really identifying those places and spaces and things and feelings and kind of everything about what triggers you to feel that craving. And then reminding yourself and having a plan for exactly how you experience that craving and what you're going to do about it. The 3 things that Tatarsky talks about are, I think distance. No, I'm not even going to try with this. Basically, giving yourself some space and some time away from wherever that kind of urge just came up. And in doing that, every time that you do that, instead of giving into that urge, you are creating a new neural pathway for how to relate to and how to respond to this distressing feeling. So assessing risk, this was a tricky one for us, and which is why it's just a list of assessment questions. What we really came to realize was this is what we're always doing at all times. And really what this is all about is getting comfortable, getting to know your client's behaviors, urges, cravings, experiences, all of that stuff, so that you can support them in moving through that, but also know what it looks like for to help them identify kind of what it looks like and what it is that they are doing and why they're engaging in it. So for instance, maybe a high school athlete that purges before they have a big track meet, or an EMT who is stressed out and goes home after work and has 4 to 5 beers every night just so that they can leave it behind. Our role as the clinicians, as the providers, is to help them explore what that behavior looks like for them and what it's doing for them. And in doing that, you're consistently assessing for risk, which is something I think that we all are doing with our clients at all times anyways.
And we also make it really clear to them in terms of, if there's suicidal ideation, just like everybody else is required to do as a social worker, if you are in danger, right? You're in danger of hurting yourself or others. That's such a loose interpretation. But if someone is actively suicidal or is going to get in their car and drive, it's not like we're like, oh, that's cool. We will do what we need to do ethically. And if they choose to go and get in the car, we will call the police. If someone says they are going to hurt themselves, we will try to get a crisis evaluation or get people to the hospital, or if they leave, then we will call for a wellness check. We're doing all those things.
And making sure the clients know that that is what we're going to do before they even begin to engage with us. Yeah. And having that full transparency of exactly what we have to do, and also what we plan to do if they were to say this, or if this was to happen, et cetera. But that transparency and them being able to be aware of the kind of, not consequences, but the follow-up to whatever they are saying to you is simply just trauma-informed and allows them to make the decision themselves whether they want to tell you or not, which is, again, their decision and a hard thing to sit with often. So in assessing risk, which you're always doing, reassessing, it's changing between every session, specifically for our clients, but I'm sure also for your clients in different ways. We're also assessing for the stage of change and where the client is at in their level of motivation to change, their situation, all of the factors that are contributing to why they're seeing you in the first place. I'm not going to go through the stages of change just for time's sake. I think probably a lot of you know kind of the model. But we use our sessions and we use the consistent kind of risk assessment and exploring the risky behavior as our jump off to figure out what stage of change they're in. And a client might be obviously in, the pre-contemplative stage of change for leaving their relationship. Meanwhile, might be totally ambivalent about the alcohol that they're using, even if they can identify that it's in response to feeling distress in their relationship. So being able to sit with them through that and help them identify that's where they're at. And in that, being able to acknowledge and sit with the ambivalence.
So number 5, jumping back for Andrew, Tatarski is affirming the client's ambivalence. And again, Glenn did talk about this morning. People are stuck. And this is the thing we struggle with most, I think, as partners, as clinicians, is like we want to help people move. But sometimes people are comfortable where they're at or just aren't ready to feel like what it is going to be like to be in a different place. So ambivalence is not a bad thing. Important to remember, just a constant reminder, is don't do more work than your clients. And that's, we always said that like when we're, doing case management, like, you're running around, you're making these phone calls and stuff, and, because you want to get it done, you want them to be successful. But it also applies to the therapeutic process. I know if I'm like asking too many questions or putting out too many suggestions, like I can feel that like when I look back on it. So just letting people be where they are while gently putting forth ideas or therapeutic interventions, but just not spiraling. And I guess I want to say, years ago when I was going to therapy for one specific issue, and we did this exercise earlier. This therapist just kept wanting me to go to like trauma-informed hot yoga. And like for anyone who knows me, like I hate being hot, I hate being cold. That just like sounds like a nightmare. But it kept bringing it up over and over again. It like wasn't hearing me. It was super annoying. And ultimately I was like, I can't go back there.
So Tatarski's 6th principle of incorporating harm reduction into your practice is another really important one. I guess they're all really important, but setting positive change goals and then celebrating the small gains. Even, and saying small, I don't necessarily want to use that word, but I'm not entirely sure another word to use at this moment. But really celebrating every success in the client's progress towards their goals. Right? So if that means one less cigarette a day, if that means using condoms one more time a week than they would otherwise, if that means drinking an extra glass of water a day, or drinking water between every drink they have, even if they are binging on alcohol, right? All of those things are all wins in the harm reduction world. And that doesn't often fit with the traditional psychotherapy approach. And so that's another huge piece that is really important to remember in this work.
Click it.
So we want to kind of talk about the different substances that we see our clients use. And in that, kind of explain to you what our approach is to clients while they're using substances, keeping in mind that our clients are adolescents, and so they are often on their own for the first time. So we are doing a lot of psychoeducation. That is kind of our go-to, so that they are informed about what it is that they're using.
I think this rings true not just for adolescents, but for humans, is, the reasons why people use. It's pleasurable, you connect with peers. I guess with our youth, you get attention from adults. You either are getting attention from the adults at the teen center, or you're reaching out to parents for positive or negative attention. But I mean, substances serve their purposes: regulate mood, alleviate boredom, relieve pain, numbs emotions, weight loss, energy, fills a void, hunger, way to take power. So many different reasons, right? So we get it.
And in our work with them, as we're educating them about the effects, the impacts, the potential for all of the substances that they use and or the risky behaviors, we are not in any way, shape, or form trying to scare them into deciding that they need to be abstinent, right? We are simply giving them the facts that we know. And they might not even be all the facts, right? We are not the experts in the substances, our clients are. I often learn new things about potential effects of substances from my clients. And so, yeah, just kind of staying open to learning new things, but also, again, checking your own kind of judgments around those drugs, substances, behaviors, and your own concern about their engagement in them at the door, remembering that they have self-determination and they get to make those choices themselves. All that you get to do is explain to them the facts.
So again, keeping in mind that we're not medical providers, did just kind of want to run through a few of the substances that we see commonly used by our youth, but marijuana is being commonly used by everybody these days. For the most part, when I ask a new youth that I'm working with about substance use, no, I don't do drugs. Okay. Do you smoke weed? Well, yeah. Okay, so it's not even identified as a drug anymore, right? So I would say, I don't know, 75% of the clients that I meet with at the teen center have used marijuana that day. Psychiatrists are prescribing marijuana now. We have the dispensaries, it's legal here. It's being prescribed for PTSD. I don't have a thought either way. I think it can be both positive or negative depending on the person and what it does for the person, right? Not with our youth, but I know a common harm reduction approach these days is people are microdosing with edibles, and but I don't think that my youth would do that, but maybe. There's not a lot of randomized control trials on marijuana, so it's impossible to know. You will never have a concrete answer around that. But it is true that for under 18-year-olds, 4 times more likely to develop a substance use disorder later in life, and it can cause an increase of depression and cognitive decline. The thing that we most worry about is psychotic episodes. So for the most part, people come to my office and they've smoked weed, or they self-report that it helps regulate their mood. It chills them out, it makes them feel better, and I actually can visibly see that. And then there's the client who is bawling her eyes out every other day, and it's like, I'm freaking out, man, and and so I'm just doing a little behavior chain analysis with her and tracing back, and then what, and it keeps going to, oh, I smoked a blunt. All right, well, so that blunt that you keep smoking, I'm thinking maybe it is having an impact on you, and that marijuana causes anxiety for you. Maybe it's worth looking into what strain you're smoking. Is there one that doesn't cause anxiety for you? Because this is what I'm seeing, right? The other thing is that we put out to you is that our clients are coming into our office with stubbed out joints and blunts, and it stinks. So if you have any harm reduction ideas around how to close that up, not in a glass jar, that'd be great.
Just knowing that they're then going back out into the community, right? And maybe going to apply for a job, or going to meet, their old teacher on the street. And so just helping them be aware of how they're presenting, and that we will allow them into our office, obviously no matter what, but that we're also humans and we can smell, right? And that's okay. That's totally okay. But are you aware of that, right? So alcohol, another gateway drug, is a tricky one at the teen center. I think that it's largely normalized in our society, and that it's seen as only a bad thing if someone has a problem with it. A lot of our clients are, again, on their own for the first time and have only been kind of given the messages that alcohol isn't as scary as all the other substances throughout their lifetime. And so they get to the teen center. There are other youth drinking out front, outside. They're gonna try it, right? In the moment, they often learn, oh, this is great, it gets rid of my social anxiety, I feel invincible, and then they feel terrible after. And so it's just helping them understand what's happening for them, and they're used to feeling terrible a lot of the time, and helping them understand, no, that actually isn't because you're just used to it. That actually is the effect of the substance that you used, so that they can then make that decision as to whether they want to induce that feeling. If after they know everything that there is to teach them about alcohol and its impacts, they're still going to use, which the majority of our clients still will, as adolescents, that it's about teaching them how to reduce their risk of harm while they're drinking. So whether that's topping off their drink with water or soda, drinking water between every drink, which is, I guess, something that people do in Europe. It is making sure that you're with friends that you trust, kind of all of those paramount harm reduction tactics when using and applying them to the use of alcohol as well. So informing them about the risks of alcohol, allowing them to have self-determination around their use of it, and then making sure that they know that there are also things that they can do to reduce their potential for risk while using.
Again, just kind of threw together some of the things that we see our youth use. MDMA. Mostly what I want to say about ecstasy and Molly right now is that people are buying drugs off the internet right now, and that's a really scary thing for us. Luckily, we have an open enough relationship with most of the youth that I can say, what are you using? Why do you look so fucked up? Like, what did you use today? But also, it's pretty amazing that, the youth will come to us and tell us, like they might walk by me and be like, I'm gonna drop 2 tabs of acid a day, boy, and I'm like, cool, so they let me know. But this summer, there was benzo sour gummy bears. Like, so I don't know, that just doesn't sound good to me. So then we refer to the experts and we'll tell community policing, and we'll tell Zoe at Needle Exchange, like, hey, there's sour gummy bear benzos. Because we've had youth get liquid benzos from Russia and almost die, and so that's a lot of where people are getting these pills and different substances, and there's that invincibility layer to it, or maybe it's ambivalence of like, oh yeah, I'm gonna totally try that. So these are the things we worry about when we hear that there's new ecstasy or Molly. We're thinking like, where did that come from? And they're used to, and maybe still is, Dance Safe, where they would test things. And I know that the Needle Exchange has started using test strips, so it's just encouraging youth, to take the time to go and kind of get what they're going to take checked out. And then with something like MDMA, it's having water on hand, encouraging people wearing loose layers, having a friend with you who's going to keep an eye on you, and and making sure your phone's charged, things like that. In terms of heroin, I want to say that at least with our youth, they are more likely to be abusing Suboxone than heroin, which is medication-assisted treatment, and that is not a bad thing in terms of risk, other than the body becomes dependent on it and they need it, and I would love for them to have it prescribed through a clinic. Heroin, from what I understand, is an amazing drug, and I understand why people use it. It causes euphoria, pain relief, diminished anxiety. Problem is you become dependent pretty quickly. When we have people that are using heroin or Suboxone, or we are always referring people to the needle exchange to be using as safe as possible. And also giving out Narcan or linking people to resources to get Narcan. What is your website? How many minutes? Okay.
For the sake of time, I'm going to breeze through this one, but it's so cocaine, crack, stimulants in general, again, educating the client about what's happening in their body, specifically with the dopamine receptors being kind of jazzed until it wears off, and then all of a sudden you crash, and helping them understand that that's actually a process that's happening in their body and is not just life. It's something that they can actually control, right? And so then they get to decide whether they continue to use it or not, but helping them understand that that is something that they actually do have power over. A major harm reduction tool for anybody that is using crack or cocaine is a safer crack use kit, which I believe you can get from Zoe and the Needle Exchange, but basically includes a clean screen and rubber ends for pipes, and that's so that you don't burn your lips, which is going to cause more transmission of HIV and Hep C if you're sharing your pipe with people.
So
No, let's just keep it. Okay, go.
Okay. The last drug that we're going to talk about super quickly, and I just want to mention it because this is what people are using most these days, and that's meth. When I lived in California in the 90s, that was the drug of choice, so I was surprised as I moved through the country that there wasn't an epidemic the way there was out there, but there is now here, and we see the youth using it quite a bit. It's cheap, it's easy access, gives you energy, you can go to work, you can stay up all night, you lose weight, you feel great until you don't. What we're seeing a lot of is drug-induced psychosis, and you can't necessarily do therapy with people who have drug-induced psychosis, but we can reflect back, after people have gotten some sleep, this is what it looks like for you, this is why you're feeling this way, and kind of, wrap around. But that is the most used drug at this time. We only have a couple more minutes, so we're just gonna jump.
So also hallucinogens, you want to be careful if you are working with a client that's actively using hallucinogens, that you probably don't want to meet with them while they're actively under the influence of hallucinogens. You don't want to become a part of that paranoia and or of their trip. And so to keep both you and your client safe, I would refrain from meeting with them while they're under the influence. However, that is always a clinical judgment, right? And if it does seem like they actually aren't really under the influence, we're not telling you you can't.
Let's get that. Okay. So we were going to do a few more substances, but I think one of the things that we'd like to get to before we have to end our time with you is to talk about a little bit about the specific populations that we work with. One of those populations is individuals who have experienced sex and labor exploitation. We used to have a subcontract with Preble Street Anti-Trafficking Services, and so we were doing counseling with a lot of men and women who've experienced human and labor trafficking, and here's what we learned in terms of harm reduction. Don't make assumptions about people's relationships. Don't try to build language that doesn't exist or doesn't need to be said. It's more about providing safety. Are you going to jump right in and do trauma counseling while someone's living in crisis or currently living their trauma? No, you're not. You're just going to create a safe space, and you'd be surprised that years later people might pick you to be honored enough to do the work with them. I said, meet them where they're at, sometimes on the floor, and that's really real. I've had sessions with a young woman sitting on the floor, bawling their eyes out, texting back and forth with their pimp, and that's all they did for the hour, and that was okay. talk about the power differentials and dynamics in a relationship without calling it what it is, but also validate, but also do education. It's finding that balance again, but validate how complicated relationships are and how important connections are, even if society would deem them as unsafe. And so that's kind of saying, I know what's going on here. I'm here for you. I can sit with your story. We don't need to do any more than that. And non-traditional safety planning, Annie and I were talking about this. It's amazing the information people will give you. If they're going to meet a trick and they're not feeling certain about it, whatever, we'll say, like, do you want to just write down their address or their phone number, and she'll have it put them under her bookshelf, and she'll I won't even look under it unless you're not back by this time, and I'll slide it under my computer, my mouse pad. Just be like, so if you're not back Sunday by 8, when you're telling me you're back Sunday by 8, then I'm going to look at this, and clients will do it. So
I was
that's
thinking
amazing.
I probably have probably 15 addresses under my bookshelf
Yeah.
still, because they come back
Yeah.
often. You want me to do that? So also just the tangible needs that, and not kind of taking those for granted, that those are really important, and that trying to do trauma therapy and/or therapy at all with someone who hasn't eaten in 3 days isn't going to work. So what they're needing in that moment is food. So how can you help them get food? So we work with a lot of mandated clients, whether they are referred to us by their JCCOs or their probation officers.
Or
also-
DHS.
Or DHS, and we also are mandated reporters at all times, which means that we would have to report any concerns about abuse or neglect to a child. This gets really tricky when we're working with pregnant moms who are also potentially homeless and/or in really vulnerable situations. Some of them potentially are also trafficking victims. And really all that we can say about this is to validate how tricky it is. We don't have the answer here. We come from the kind of trauma-informed approach that pure transparency is absolutely essential. And so making sure that every mom that I meet with, any client I meet with, in the first session and throughout our work together, I'm going to outline the exact protocol that I have to follow if I'm concerned about something that they tell me that might include abuse or neglect of a child. I also include them in that call, and I let them know that. Not an easy thing to do. Absolutely not an easy thing to do, especially when you have a really tentative, tenuous relationship with a client who is at acute harm or acute risk of harm. That transparency, again, is essential. Oftentimes, the moms that we work with have had the department called on them by different people in their lives, and oftentimes it's used as a tool to hurt each other in their kind of informal network of supports. And so helping them also understand DHHS and our role as making sure that children are protected, aligning with them around that. We are not trying to get them in trouble. We're not adversary to that. We are with them in that process, and they also want what's best for their children. So again, that psychoeducation piece around substances and just sitting there with them through it is, again, essential. Do you want to talk about something next?
I guess one thing I want to say is Subutex is what's prescribed when someone is struggling with opiate addiction and they're pregnant. And I've had clients really feel some shame around being prescribed it, and I'm always a huge advocate. An infant still has to go through a mild detox when the mom is taking Subutex, but it is so well managed, especially at Maine Med, and so encouraging a mom to be honest about their use and get on Subutex is it's an interesting conversation, and being there to support when the child is going through their minor medically monitored detox. Okay, so we have 1 more minute left, we're being told.
Just one more piece of working with mandated clients is that we work really closely with lawyers who advocate really, really strongly with the DA and prosecutors around making sure that they know that if a client is mandated to treatment that requesting all of our records on a client is not going to be helpful for that client. And so we are really lucky to have that relationship with the lawyers that are doing that work, and to be able to share with the lawyers who then get to disseminate our experiences with that, because that really can be a barrier to client-centered treatment.
I guess I just wanted to say, since we have 1 minute left, harm reduction is considered controversial amongst some communities, and I've even heard the language used like, "Oh, you're enabling clients," and that's absolutely not the case. It's meeting people where they're at, and we were going to go on to talk a little bit about challenges to keeping formal treatment client-centered, and we were going to talk a little bit about treatment planning goals and things like that, but I think more important than that is talking about, just the interest of time, the realities of safety planning. And that's a hard thing, because when you are working with people who are engaging in potentially harmful behaviors, and I felt this true when I was a younger clinician, is like you just wanted that guarantee that that person was not going to hurt themselves, that they were going to be okay. And that just doesn't exist, right?
Even if they do safety plan with you, right? That guarantee is not there.
And that's a hard thing, but we do our best, and that's all we can do. So.
And getting support around it from your colleagues and your peers is super important, and obviously making reports when you have to. So going outside of your office when you need to, and again, being totally transparent around what are the situations that you would need to do that.
And so that is what we have. Does anybody have any questions? I don't know if we have any time for questions. Yeah.
So one of the dilemmas that I come across is like when I have to have a client sign paperwork, like a release of information or their treatment plan, but they're not necessarily sober at the moment. You were going to mention that. I would be interested in, like, how do you handle a situation like that? Is it even legal?
Well, right, and that is like our biggest cross to bear, and we do have a coworker in the audience, is keeping our paperwork up to date in a timely way, right? You're expected to have things signed at a certain time, and someone comes in and they're super fucked up. It's like you're not going to have them sign that, So that is an interesting question. We do our very best. Yeah.
I think it's about, we constantly are using our kind of clinical judgment and then checking in with each other about it. My go-to is, are they going to remember this? And if not, I'm not going to have them sign anything. I'm probably also not going to do a session with them in that situation. But if they are stoned and they come to session stoned every week because that allows them to get to session, then I probably would allow them to sign paperwork if that's their baseline. But again, that being said, there's no hard and fast rule for it, and it's really up to your clinical judgment in the moment. Good question.
Yeah, thank you.
We'll take one more question.
So when I describe harm reduction to clients, sometimes the feedback I get from them is that they feel like they're then giving themselves permission to use when maybe they want to abstain. Kind of what are your thoughts on approaching that conversation?
I would say that, treatment's different for everybody, and if your client is more drawn to the abstinence base, like, I'm saying for me and my experiences, like, I think harm reduction is really effective, but I also think abstinence is effective as well. Just so if that's the goal that they're drawn towards, then I would say work from that model.
I would maybe use some kind of motivational interviewing to help, I'm sure you do, to help them kind of identify, are there any things about using or about that behavior that they don't like, and kind of trying to resolve that discrepancy, get them out of that ambivalent state. But also wondering, I would definitely want to know, why do you need permission to use, right? And kind of exploring that, like, why does it matter that I'm not telling you can't? And yeah, essentially helping them kind of re-own that self-determination around their actions being theirs.
Great. Well, we actually have a break for a half hour, so I think maybe during the break, if you want to ask Cheryl and Annie some questions offline, Would you be willing to answer and
Sure.
meet with people? Great. So let's give
Thank
them a
you very
hand.
much.